Thank you very much, Warren. And it's an enormous pleasure to have followed Jill's outstanding presentation, because in a sense, what I'm presenting has a very clear link to the model and to the approach that she was presenting. So the title of my presentation is The Development of a Modular, Multifocal, Therapeutic Approach to Addressing Childhood Adversity. And I'm going to be talking about the hope for children and families, intervention resources. I'm sure that it's obvious that adversity has played an extraordinarily powerful role in all our lives over this period. And the relevance of working with adversity is becoming ever more clear. So I'm associated with the child and family practice in Bloomsbury, an independent practice, child and family training, a not-for-profit training organization whose goal is to develop and train evidence-based approaches, resources and tools. And we're working with the Association of Child and Adolescent Mental Health to develop some collaborative training. My work has been at Great Ormond Street and the Tavistock Clinic, which I'm now retired from, and the work that I'm presenting has got long roots in our work with adversity there. Delighted that together with our collaborators, Bruce Chorpita, whom I'm sure is very well known to many in the audience, and Eric Delighten, his colleague, and my colleagues from Child and Family Training, Jenny Gray, Stephen Pitsey, and Eileen Vizard, we published literally last month this paper in Child Abuse and Neglect, which describes the value of a modular multifocal therapeutic approach to addressing child maltreatment. And what the presentation today is extending this to look at the field of adversity. And I'm going to send a copy of this paper to Warren, so so if people would like to see it, he'll be able to distribute it. There are two important trends in the field of adversity at the moment. The first is the development of the concept of ACEs, adverse childhood experiences, and the second is the growing awareness of polyvictimization, the theme of multiplicity, multiple responses, which is so important. Comorbidity in mental health field is very similar in the field of adversity. And this diagram by Shanti Dube, which describes the 20 years of research in adverse childhood experiences, describe the way that childhood adversities, abuse, neglect, and stressors in the home, which is the important element that's been added to different forms of abuse. Adolescent outcomes is associated with substance abuse, suicidality, pregnancy, mental health, sexual risk behaviors, a whole link with a series of adult outcomes, chronic diseases, substance abuse, mental health, suicidality, emotional dysregulation problems. And this, of course, affects parenting, which in turn leads to a cycle of adversity. And I think the fact that over 40% of mental health problems in children and young people are associated with adversity demonstrates how important the theme of adversity is. Polyvictimization theme introduced by David Finkelhor, and this looks at, and this is just the results from a rather key piece of research between Maudsley and University College, which demonstrated that the more maltreatment types individuals were exposed to, the more likely it was that there would be high levels of externalizing and internalizing disorders. And in the in the self-report of young people, these are young people in late adolescence, early adulthood, reflecting on their lifetime of adversity, demonstrates that the number of maltreatment types, the higher the levels of internalizing difficulties, anger, irritability, PTSD symptoms, and dissociation. The impact of stress, which of course, very well known, positive manageable stress, and extensive adversity, complex trauma, toxic stress, traumatic responses. And an important paper, which was published by Andrea Danesi and colleagues, demonstrates the importance of exposure to adversity. This was a study which tracked over 2,000 twin children born in England and Wales between 1994 and 1995, and exposure to victimization risk factors were assessed at 5, 7, 10, and 12. Cumulative information was obtained about exposure to domestic violence, bullying, physical and sexual abuse, emotional abuse, and resilience factors, personality, family, and community factors. And the psychiatric assessment was made at the age of 18. And the important finding from their study was this: that trauma-exposed individuals had much higher levels of depression, anxiety, ADHD, conduct problems, alcohol, cannabis, psychotic symptoms, self-harm, and suicide. And a further, more recent study, Stephanie Lewis and colleagues published in the BJ Psych last month, demonstrated that complex trauma risk, multiple events, interpersonal assaults, threats, repeated abuse, severe bullying, resulted in much higher levels even of PTSD, generalized anxiety disorder, psychotic symptoms, cannabis dependence, and nicotine. And of course, the issue is how are we going to work with adversity given the complexity of the experiences and the complexity of response. There's a lot of discussion about ACEs-informed practice, trauma-informed practice, and the need to develop practice across multiple agencies when there's evidence of maltreatment. But most intervention research and practice focuses on single disorders, limited availability of intervention to meet the complex overlapping mental health responses, and recent paper, effective scalable interventions to prevent the emergence of mental health children have not been identified. I think we're all of course, increasingly aware of the general psychopathology factor, commonalities in overall internalizing and externalizing dimensions. Specific factors account for differences in presentation. And of course, we know that a variety of psychosocial interventions are effective in improving mental health problems. And transdiagnostic factors include negative emotionality, emotional dysregulation, and irrational thoughts. And of course, this may account for a variety of mental health responses and a relevance to modular approaches to intervention, which is the approach which we, together with Bruce Chopita and colleagues, have developed and which I'm presenting briefly today. I think it's very well known that the modular common practice element approach is to do with developing therapeutic procedures for specific presenting problems from an empirically derived bank. As I'm sure colleagues are aware, that common practice elements, Bruce and co, have derived these from single focal treatment manuals identified from more than 1,000 control trials, and they're catalogued online. And the research, the modular approach to anxiety, depression treatment is an intervention system that incorporates procedures and coordination corresponding to 4 successful evidence-based interventions for anxiety, depression, conduct, and trauma, modifications allowing it to be used as a single protocol. And of course, there's research by John Veit and Chopita and colleagues, which demonstrated that the match approach outperformed focal treatment manuals for anxiety, depression, and disruptive conduct and was superior on clinical outcomes. So we worked with Bruce and colleagues to look at the common practice elements from evidence-based RCTs to prevent the impact of adversity. And we also looked at the common factors, framework, personal, interpersonal components. And what we did was to focus on a tool which we've been involved in developing since the year 2000, which is the assessment framework, which is the map of relevant data to be collected across the welfare field, and which we think has got very considerable relevance to looking at interventions for adversity. And the assessment framework looks at the child's developmental needs, which of course includes emotional and behavioral development, parenting capacity, and family and environmental factors, all the factors which are known to be associated with whether adversity is displayed and severity, and many of the other factors. And what we did through our extensive piloting was to take the various elements that we had identified and developing them into a series of guides with briefings, content, steps, scripts, guidance, activities, role plays, handouts, worksheets, because we felt that it was essential that both experienced practitioners should be helped to know what are the best evidence elements in terms of working with adversity, and also to introduce colleagues across the different intervention fields, which is how we did our piloting. And you can see here that this is the triangle, and this is the set of guides that we developed: engagement, modifying abusive parenting, promoting development, promoting attachment, promoting positive parenting, working with families, working with child sexual abuse, working with emotional and disruptive behavior, and working with emotional and traumatic responses. So briefly, just to tell you the sort of modules within each of these guides, including engagement, hopefulness, goal setting, modifying abusive and neglectful parenting, psychoeducation, managing stress, transforming perceptions, clarifying, reconciling, promoting development, early and later development, promoting attachment, secure, to make for secure attachments, promoting positive parenting, understanding behavior, positive attention, ignoring, working with families, healthy communication, problem solving, managing conflict, working with, and a key, working with emotional and traumatic responses. And you can see here that we have suggested that a core set of tools, developing a child-centered approach, understanding the impact of maltreatment, safety, coping, relaxing, monitoring, activity selection, and problem solving, would be applicable across the whole field of responses to adversity. And then in addition, there are modules on working with anxiety problems, mood, trauma, maintenance, and building resilience, and working with disruptive behavior includes competence, coping with behavior, assertive training, making positive relationships with family and friends, and working with sexual abuse, safety and care, supporting work with older and younger children responsible for sexually harmful behaviors. An important development, which we have in a sense linked this, is the profile of intervention, which we've introduced over the years as a way of working with adversity, to have a 7-stage process, looking at the referrals and the aims of protecting children, gathering information, organizing the information, analyzing strengths and difficulties, making judgments based on a systemic analysis, and making decisions and implementing the plan of intervention. So in a sense, this is this is an approach where basically we draw information together. And because of time, I'm just going to very quickly demonstrate the way in which we could put together a management plan. This is a family where there's major conflicts in relationship to the mother's 6-month illness, leading her to use a wheelchair, very much a psychosomatic fibromyalgia sort of problems. The result relating to this was high levels of challenging behavior and truancy by one of the young people, strong alliance with father, doubts the severity of the mother's condition, the father's irritation with the older boy associated with his own frustration. Paul is taking on the role of the carer, and the younger child shows oppositional behavior. So this is a very brief account, and the approach that we take is to say that we organize the information here using the 7 stages, and then finally come out with an intervention. So here's the intervention. From the goal setting engagement guide, we are suggesting that the goal setting is that the mother needs to obtain consultations to resolve the confusing aspect of her illness. The father needs to be more supportive. There needs to be restructuring of family alliances, parents to assert themselves. David has to have regular attendance, appropriate relationship, and to be helped to reduce oppositional and disruptive behavior. Paul to be more independent, and Michaela needing to be close to both her parents. So just very briefly, the idea of modifying abusive and neglectful parenting, looking at sources of parental stress, promoting well-being, identifying the care needs of each of the children, and working together for parents to ensure behavioral responses are tackled. Review attachment patterns and repair the attachments between parents to one-on-one time. The idea is often that the work needs to be carried out with parents with or without children as a core approach, and then working positive parenting, reasserting parental skills, and then working with the family as a whole, particularly if there's a separation and there's a need for families to be rehabilitated. And then the mother's disability and responses have created a traumatic response. The toolkit of generic skills would foster the children's resilience through understanding the impact on each of them, developing coping skills, relaxing self-calm, understanding, managing feelings actively, positive effect on mood, and of course, working with David to address disruptive behavior, manage his anger, reduce disruptive, verbally aggressive and impulsive behavior, finding appropriate ways to assert himself and to develop a good life, socially acceptable. So terribly brief account of developing a set of modules based on the core elements of what's effective, and then finding a way of integrating them into a set of practitioner guides which are relevant across the field, and then sorting out with the particular family which element of the library to apply, and then working with different agencies to decide which of these guides would be relevant to their work. Sorry, that's a terribly brief account of a very complex and development. But
thank you, Arnon. That's magnificent. You did a marvelous job of condensing such detailed and really important, fundamentally important information. So well done to Arnon for your.
Thank you very much.
Thank you very much. That was really important piece of work. Next, as we can see, we're just going on time here. The next speaker is Louise Mansell, who is my wife, and she is zooming in from downstairs. She's going to be sharing with us an online ultra brief workplace stress management intervention, and Louise co-directs Beyond Psychology in Rochdale. So we'll pass it over to you to share your screen, Louise.
Okay, I'll do my best for you here. Hi everyone. So just checking everyone can hear me and see me okay. Yep. Super. Hi Sarah. So yeah, as Warren just described, I work at Beyond Psychology, which myself and Dr. Kirsty Hughes set up in North Manchester and Rochdale following some time in CAMS. It's a social enterprise working with families, young people, schools, and services, I suppose, that want to become trauma-informed, which follows on nicely from the last presentation there in terms of the importance of ACEs. So all our profits go back into working with children with adverse childhood experiences, but in particular creating trauma-informed schools and trauma-informed settings. So how that led to the 4D model is that we're involved in a lot of schools. And during the COVID pandemic, in the first lockdown for the UK, we'd never had as many phone calls from school staff saying the staff are not okay. Very rarely do you get teachers more concerned about themselves than the children. They were concerned about both. For one of the first times, we were always trying to, within the trauma-informed model, promote well-being for staff. But it felt like this had really become of national interest, particularly for head teachers. So this started during a really difficult period for everybody, with a phone call saying, I have 50 staff, Louise, who are not okay, and 90 minutes at the end of a school day. What can you do? And the answer was, leave it with me. I knew there were strategies that would be helpful for everybody. I knew there were some strategies within our service that we always promoted. And for us, the trauma-informed approach to running a service, the trauma-informed approach to running a school, made sense across diagnosis. It was always been transdiagnostic. It was a safer way to do business. It was a safer way to treat children. If you treat everybody in a way that is okay for those with the most traumatic experiences, it's okay for everybody. It's the most compassionate way you can work. So this kind of transdiagnostic way of thinking about well-being just seemed to fit. And I thought, I'm sure there's something we can do that will cut across whatever distress some people are dealing with. Some of these schools had children there with short lives who were really threatened by the COVID pandemic. And other schools had children with a lot of child protection issues, so they were in schools. So a lot of our schools had a lot of children attending. So this led to a big conversation with Warren, whilst homeschooling, of we've got 90 minutes, how can we bring this together? And that's what led to 4D being structured in the way it is, because we had all these strategies. People will be familiar with many of the strategies I'm going to talk about, but it was how it was structured and how people understood why they might need more than they're currently doing, why they might need to do something slightly different than they're currently doing. On a real personal note, if I was during lockdown, I was thinking, if one more post on social media tells me to go for a walk and look at a tree, I'm going to scream, because there was so much of it that I was like, nobody was telling anybody what else you could do other than breathe and go for a walk. So it's not that that's not in there. Breathing and going for a walk is very, very helpful, but it's got its place. And I think that's where 4D really fit for us. It was putting all these strategies in a place that made sense for people. So I'll talk you through a little bit more about that. I know Warren's going to be watching me for time, otherwise I'll tell stories about clinical work. So you will have to forgive our outcomes and any data we've got. These aren't based on research trials. These are based on, I want to know if this has been helpful to you. Are you using this model? Because yes, we want to research it going forward, but in a pandemic, I just needed to know if it was working. And that's what our outcomes are largely based on. So there is the paper. There's a whole host of scientific background for every single strategy and every layer of this, but you can read that. That's not what you need me for. I don't need to read that to you. You can read that outside of this. I want to make this as real for you as possible, so you can get a real sense of how this looks in practice. I hope that's what you wanted. So as everything's colourful and on brand beyond. So this is hence this tip sheet that people get to talk them through this process. So hopefully you can see that it's a busy tip sheet that starts with distract, and that's how we start to introduce the model. We give a little bit of background, and for each of these levels we talk about what those strategies do scientifically. What's been a challenge for us as a service is knowing how much theory to give people about why these strategies might work, why they are sat where they are, and why they might want to try them, versus letting them experience them. Because we know that if you give somebody a rationale for something, they're more likely to do it, like your 5 fruits and veg, why you might exercise, why you might take vitamin C. If you know why, you're more likely to do it. But at the same time, we had 90 minutes and we wanted them to feel better at the end of it. So they experienced it and then would be willing to do it. So we've got a lot of data on if we spent enough time on each of these strategies. Fortunately, distract is a big one. Lots of people spend a lot of time distracting themselves, whether that's watching TV, going for a run, reading, having a bath. So the idea would be to ask people, what distract techniques have they already got? So you're empowering them to come up with their own, because everyone's will be different. For example, some people would run to distract themselves. Other people will run to think about what's on their mind. And therefore, if you're running to think about what's on your mind, it doesn't fit in distract. And getting that sense of that's more in dilute, because running helps you regulate as you're thinking about it. Some people will use music as distract. Some people will use music to really think about what's on their mind. So helping them identify what are their distract techniques and when might they use them. Clinically, what was really interesting when you start to ask people about this afterwards, because I've done it with parents as well, and then ask them about it, they've realized that actually most of the strategies they have are in distract. They spend a lot of time in distract, and this workshop's helped them think about not overly investing in distract. I think that's, as a society, we probably talk about distracting a lot more than we do about developing and discovering. So we wanted to make sure we got to discover all the time. So we did review distract quite quickly, then going up to dilute. So you'll see there we've got square breathing, grounding techniques, mindfulness, progressive muscle relaxation. So this model was never about introducing some novel strategies, introducing things people had never heard of. This was about introducing them in a way of, this is where this fits. Absolutely, mindfulness is very, very useful, but it fits with diluting and being able to tolerate distress sometimes. But any of these alone are often not enough if something's continuing to bother you. That makes sense. So that's where your breathing and you're going for a walk comes in. That actually, if you're going for a walk, you're doing mindfulness every day. You're reading to distract yourself, and you're still managing to not sleep, not eat, not concentrate, or something's still on your mind. You need to go up a level. And that's what we were presenting to people. And usually you'd see when people did put their screens on, which we did encourage, when you're talking about that, people are nodding their head, say, yes, they're still not sleeping, and they're doing everything they're being told on social media, and they're still not sleeping. What we wanted to make sure, particularly at Beyond, because we very much work in a trauma-informed way, to make sure that you're not asking somebody to discover something and bring something to the surface that they can't tolerate. Very, very important for our work with children, but I think very, very important for our work with adults. What you sometimes get in our NHS and CAMS services is this idea that people have disengaged. What we want to think about, Beyond in particular, is maybe they're just not ready for that work. I've not disengaged with running a 10K. I know that I need to train for that. I don't book one in until I've trained for it. And for me, that's where develop sits. How can you give somebody the confidence that they can handle what they're about to discover? Because often what they're about to discover is the upward arrow, or in PCT, going up levels. But we want to make sure that's tolerable. We want to make sure that they've got the skills there to do that. So we would do some sort of compassion focused work, informed by Paul Gilbert, so they can bring images to mind. That might be compassionate images, it might be funny images. You can mix it up depending on the audience. You can introduce them to a worry time so that they know that actually, yes, do this discover, but actually give it a time that you're going to do it. And actually, when you've done discover, which is the next part where you're really investing in thinking about this problem, talking about this problem, asking yourself questions about it, getting someone else to ask questions about it. Once you've done that, you might then need to go down to do your dilute strategies because it's a bit much. So you can't live in discover, you'd never get anything done, but you can't continue to stay in distract either. And giving them this real sense of this model and how to structure what they need, and letting them pick that sometimes grounding will work for some people. Some teachers in really difficult to work in schools where there's high rates of exclusion, and they were teachers that were excluded, don't like mindfulness in particular, but they might be able to do something like progressive muscle relaxation. So allowing them to think, okay, I'm going to start doing that after I've had this session of discover. Within discover, we introduced the upward arrow technique. We would ask even online questions about upward arrow technique. We would ask them questions so that they could be thinking of the answer. The beauty of may I say, the beauty of Zoom is that people could answer while they were on mute. And for us, that didn't matter because they were hearing their own answer. And you'll understand if you hear something, you're more able to reflect on it than if it's just stuck in your head. They say it out loud and they're able to think more about it. Some people would choose to write it down. What was really fascinating for us as clinicians is people were very willing that they'd get upset. They'd be sat in their own house getting upset doing this workshop, and you'd not said a word to them about it. You'd not actually personally spoke to them. And they'd turn their computer off and then they'd come back. And we started introducing that to say, if this gets difficult, if you want to turn off, just please try and make sure you come back. This led us to actually work in the model, work people up to discover and then go back down so that they actually left the session regulated and they'd practiced a few of these strategies at every level. So we kind of build them up to this and then take it back down. We've done it live and we've done it online. I've done it for a range of groups. We've done it at primary schools, secondary schools, for NHS staff. That's the whole list of people who've attended this since it was published, really, in December last year. And I think the real hope for us as psychologists was that we had something we could do that could make a difference at a time when that was the main thing you wanted to do as a clinical psychologist, for sure. And I suppose it felt like it did. Again, with the outcomes, people have felt more confident in dealing with their distress after attending. These were our questions about the pace of the workshop, because we were very aware that it was 90 minutes and we had so much to say. But school, you can make it longer. So if it's an organisation, they can have 2 sessions of this. But ultimately, schools, for anyone who knows schools well enough, they do have 90 minutes every so often for a staff meeting, and that's where this fit in. It just slotted into these staff meetings. And that's when we asked people about the pace of how much we presented and how much they wanted to experience. And again, it was different for different people. Some people were really familiar. When you're training IAPT workers and NHS staff, they're familiar with the strategies. They don't need the science. They just want to experience it as a well-being session. So getting that balance was really important for us. Overall helpfulness, we wanted to know it was helpful. This was something we developed. It was new. At the very least, we wanted to know it was very helpful or extremely helpful, which fortunately we found out it was. What was really fascinating for us is that on some occasions we delivered this to 25 people, and on some occasions 150. And there's no difference in how helpful people found it when we delivered it to 150 and 25. Now, why that's brilliant news for practitioners is if you can deliver an intervention to 150 people in 90 minutes, we might actually get a head start on this mental health crisis that we are now in, if we weren't before. So we wanted to know whether people were using all the strategies. Interestingly, I know we're planning to think about this more. I'd be really fascinated as someone who's talked to people after this, is how much people don't use develop and discover as much until after this workshop. They don't quite get the value of discover and talking about your difficulties and doing free writing until after this workshop. And you end up with teachers saying, oh, is that why it's helpful when I talk to myself? And you're like, yes, you've got full permission to talk to yourself following this workshop, because you're hearing that story out loud. But the free writing, expressive writing has been a really powerful tool for people. So we've got a lot more data to collect in a lot more of an official way than we have done so far. But I think one of the things we'll find is how much people use Discover more after this workshop. That's some of the feedback in person there, which you can have access to at any point. I'm not sure of my timing. I'll carry on until Warren gives me a warning. I'll let you read that for now.
You could look at your chat, but you've got 4 minutes, however you want to use that.
Super. So yeah, comments about finding the hierarchy of it and how it was structured, really helpful. As I said, some people were saying these aren't new strategies, and we started by saying a lot of these strategies won't be new. That's not the idea. We're wanting you to understand where these strategies fit for how you're coping, and when you might need more different ones, when you might need to switch strategy. It was just very powerful to see the effect of it, even when it was online to a huge number of people. We're then going on to develop this model in terms of train the trainer, because there's services, there's organisations that want to be able to do this very workshop, and we're hoping to be able to train the trainer in that. We've got an introductory session running, which the link's there. I could put that in the chat box actually. Warren, could you do that? Pop that in the chat box so people can click on that straight away and hear more about it. A larger goal from researchers involved in this is that this public health model, and then the 90 minutes 4D interactive training in discovery talk, because we feel that that's the real bit that as a society we're lacking, is understanding the importance of that discovery talk, randomized controlled trials. As a service, we've got a real invested interest in developing this for teenagers to run. And we have trialed it with teenagers, and they've very honestly told us how it could be improved. So we're inviting them to our service to make this more appealing to teenagers, and essentially think about what teenagers could be working on at the same time as doing this online. So they're a group of young people are going to develop that side of things with us. So I hope that's been helpful and given you enough to go away and at least read the article, and certainly look at the training in this, because that's something we're really looking forward to, being able to give people the opportunity to have more training in this really effective way of treating or improving the well-being of large groups of people. So thank you, and I'll look at the chat.
Thanks very much. Thanks very much, Louise. That's brilliant. Very succinct overview. Afraid there's not time for questions, and I will paste that link into the chat shortly. Now what I'd like to do is pass over to Alberto Gonzalez-Robles, who is going to be giving the talk that Amanda Diaz-Garcia was planning to present on the profile of transdiagnostic CBT patients. And they're both from the University of Zaragoza in Spain. So Alberto, you've got a co-host. Are you there to talk to us and to share your screen? Super.
Hello, can you hear me?
Yes, I can hear you.
Yeah, nice to be here.
Super, nice to see you. Are you ready to share your screen for us? Super.
Yeah, it is the first time I use Zoom, so I hope I can share it. Okay. Oh, the system is asking me to log out and to log in again in order to be able to share the presentation because I'm using my MacBook.
Okay. Okay. I guess if it's
So
asking
just
you
give
to do
me
that, then you should do. Yeah.
Give me just a moment.
Yeah. I've just put the link there for the trainer approach for 4Ds that Louise mentioned. Just a quick note that the discovery talk aspect of 4Ds is based on method levels, which we'll be hearing more about when Abigail does her talk after the break, and there'll be some topics on it tomorrow. Here he goes. Here's Alberto coming back, hopefully with his PowerPoint operative.
Sorry, can you hear me?
Yes, can hear you.
I'm pressing this sharing screen button, but I don't know what.
Okay, what you'll need to do then, we did have this problem from Iceland. Can you email your slides to us? To me at my Gmail address.
Yeah.
And I'll pick that up and I will do the screen
right
sharing.
away.
Thank you.
To the Gmail.
Yeah.
Okay. Yeah. I'm sorry.
It's okay. It's interesting, isn't it? How some people's devices seem to work on this quite naturally, and others don't. I've got an out of office reply to do with the conference, so you should know when it's gone through because you should get that back, but it's not appeared at my end quite yet. Sorry everybody about the wait here. We have got a fairly decent sized break after this, so
yeah, it's sent.
Okay. Yep, I've got it.
Okay. So how we do this, because
yeah, you just tell me when to advance the slide. So can everyone see that?
Okay.
Yeah.
Okay. Thank you. Sorry for this problem. Well, as Warren said, my colleague Amanda should be giving this presentation, but unfortunately she cannot be here today. The presentation is titled Sociodemographic and Clinical Profile of Patients with Emotional Disorders from the Community versus Specialized Mental Health Care Settings undergoing Transdiagnostic iCBT. You can move to the next slide. Thank you. To keep it short and simple, the goal of this study was to we wanted to analyze, to compare the sociodemographic and clinical characteristics of patients with emotional disorders from two different settings, from two different randomized controlled trials that are already completed, in order to assess whether these patient profiles differ between recruitment settings and to try to use this information to personalize treatments. That would be the rationale of the study. You can move to the next slide, please. The study is a cross-sectional design. We compare baseline data from these two samples from these two randomized controlled trials. We recruited 200 adult patients from Spanish public specialized mental health care units and 216 patients from a community service, also in Spain. These two randomized controlled trials had in common that we use the same iCBT, Transdiagnostic iCBT protocol. All patients met diagnostic criteria for a DSM-4 emotional disorder, unipolar mood disorder or anxiety disorder. And the intervention that we tested was a transdiagnostic iCBT protocol. That's what that was mainly based on the unified protocol. The intervention also included some strategies from the Marshall-Linehan DBT protocol. We analyzed some socio-demographic characteristics such as age and sex and marital status and educational level. And we also analyzed some clinical characteristics like such as the clinical diagnosis using the MIMI, depressive and anxiety symptoms using the BDI and the VI, and health-related quality of life using the Eurocode. Next, sorry, you can move to the next slide. Following, yeah, thank you. This slide shows a summary of the results. Table 1 shows the differences in social demographic characteristics between these two samples. As you can see, patients from the community were significantly younger than patients from specialized care, with a mean of 33 years old compared to 38 years old in specialized care. Female patients were more frequent in both samples, and there were no differences in this variable. Regarding marital status, in single individuals were more common in the community sample, whereas married or partnered individuals were more common in specialized care, and significantly more. And these differences were significant. Regarding the educational level in the community service, most of the patients had university studies, while patients from specialized care, the distribution of the different educational levels in specialized care was more balanced. Table 2 shows the differences in clinical characteristics. We only found significant differences in depressive symptoms. Patients from specialized care were significantly more depressed than patients from the community, but we did not found differences in the remaining variables. With regard to the differences in principal diagnosis, as you can see, generalized anxiety disorder was slightly more common in the community sample, while social anxiety disorder, OCD, dysthymia, and mood disorder not otherwise specified was more common in specialized care. You can move to the next slide. To finalize, the results showed differences between these two settings in some social demographic and clinical characteristics. And these results suggest that these differences, that there are differences in the profiles of patients depending on the setting, and that these differences might be important to consider when we approach the emotional disorders in different settings with transdiagnostic iCBT. The study has some limitations. On the one hand, no directional conclusions about the causal relationship between the sociodemographic and clinical characteristics and the specific setting can be drawn. And another limitation concerns the representativeness of the results. The sample may not represent patients with emotional disorders of different sociodemographic segments or from different healthcare settings. Thank you.
Thank you very much, Alberto.
Thank you very
You
much.
did very well
Sorry.
despite the technical difficulties. So thank you very much.
Thank you.
Super. Very interesting details. We've come to a point now where we now have another break, a comfort break, or a chance for us to chat or discuss anything whilst some of us have a recuperation. And then we start again at 8 o'clock. Alberto will be back again, giving his own talk. Actually did very well giving someone else's talk. That's always hard. Followed by 3 more talks for the next segment of the conference. So thanks, everybody. Thanks, Colette, for your message, by the way. Have a really good rest of the week. So I was just talking to Colette, so thank her for her message and wish her the best for the rest of the week. Yeah, sorry, Alberto.
Sorry. I'm gonna send you the other presentation also.
Oh yeah,
okay?
yes, we'll have to do that again, won't we? Yeah.
Okay, thank you.
Then I'll make Abigail, Valentina, and Nina co-hosts. And I will stop the